for the Irish diaspora around the world. It is our national day. And with that in mind, I'm very proud to introduce our first speaker this morning. Dr. ADRIAN Brady is a consultant radiologist at Cork University Hospital. He is also the current president of the European Society of Radiology and is the first Irish radiologist to hold that role. So the entire Irish radiology community is very proud of Dr. Brady. Adrian's going to talk to us today about some work that he has been leading on the topic of value-based radiology. And after his talk, we're going to have a wonderful panel talking about workforce issues across the globe. Adrian.
Thank you very much for the very kind introduction. Geraldine has explained who I am and what I'm doing here. I'm going to talk for about the next 20 minutes or so about value-based radiology, which may seem like a nebulous topic, but I hope you'll have some understanding of why we're talking about this after I've finished. The main reason we've begun to focus on this is largely contained on this slide. This is data from the OECD showing the numbers of MR studies and CT studies between 2007 and 2017 across a range of countries. And, well, you probably can't see the pointer, but you'll see that in virtually every country surveyed, the numbers of CTs and MRs increased very substantially in that 10-year period. And the problem is that in most countries, the workforce did not keep pace. This is data from the Royal College of Radiologists 2020 workforce census, and it shows the numbers of plain films, MRIs and CTs done in England from 2014 to 2020. You can see the plain film numbers stayed about static. MR studies went up by about 30%, CTs went up by about 40%, and again, the workforce did not increase at a rate commensurate with this. So from the same report, in 2020, the UK in the whole had a deficit of about 33% of the numbers of radiologists they needed to deal with this workload. Even with an increase in radiologist numbers by 2025, the UK predicts that they will be lacking 44% of the radiologists they need to deal with the demand. So this is worrisome, and this is being replicated in many of our countries worldwide. It is a global problem nowadays. Now, you would imagine that the simple solution is throw more money at it, train more people, produce more radiologists, get on with it. And that's true up to a point, and we'll be discussing that later on in the panel discussion, I'm sure. But if you spend more money on healthcare, you eventually reach the point where you get diminishing returns. This is a simple graph showing the total expenditure as against the health of a society. And it's a notional graph, it's not based on specific data, but in general, as you increase expenditure on healthcare, societal health improves to a certain point, and beyond that, the more money you spend, the less good you're doing, because you start picking up things that perhaps don't need to be investigated, you start over-investigating people, you start over-treating sometimes. And there's a sweet spot where societal health is at its apex that we're all seeking to find. We're trying to find what the right amount of expenditure is to maximize healthcare without being wasteful. And this is where value-based healthcare comes in. Now, just to focus on radiology again briefly, how many radiologists should we have for workload? Well, it's a difficult number to arrive at. This is a paper from the Journal of Pediatric Radiology from a few years ago that looked at the number of radiologists per million of population across a range of countries. Many of us would look to the USA as being an exemplar of a well-staffed environment, although my friends and colleagues from the US will probably say otherwise when we get to the panel discussion. So they had about 140 per million of population when this data was compiled. In Europe, we often look to the well-funded, well-resourced, well-organized countries in Central Europe, like Germany, about 95 per million of population. This is where I live. We have about half of what Germany has, and many other countries are less well-staffed than we are. So nobody quite knows what the right number of radiologists is, but I think many countries certainly do not have enough. So it's against this background that the whole value-based healthcare movement has emerged. It owes many of its origins to a group in Harvard who started looking at this probably 20 years ago. And one of the seminal papers they produced on it was written by Michael Porter and published in the New England Journal in 2010, shown here on the left. But even in radiology, people were beginning to think about value before that. The Grey Journal produced a paper in 2009 about it, the JACR in 2014. The European Society published our first paper on this concept in 2017. In Porter's model, the one described in the New England Journal paper, he commented that much of the total cost of caring for a patient involves shared resources, such as physicians, staff, facilities, and equipment. And we contend that radiology is the perfect model to look at in the whole value-based healthcare enterprise, because it's a perfect example of a resource shared across all levels of healthcare delivery, all medical specialties, and patients of all ages. So we'll be focusing on radiology from now on. Now, what constitutes value? I like to quote Warren Buffett on this. He says that price is what you pay, value is what you get. So the whole idea of creating value is about producing new services or improving the existing ones to increase their worth to those who receive those services without necessarily spending any more on them. But it's not just about the money. This is a 2019 European Commission report on value-based healthcare, and I quite like the way they define the whole concept, because they say it's supported effectively by 4 pillars. Personal value is ensuring that the appropriate care is delivered to achieve a patient's personal goals. Technical value is the achievement of the best possible outcomes with the resources available to you. Allocative value is ensuring an equitable distribution of resources across all patient groups. And societal value is ensuring that healthcare contributes to societal participation and connectedness, keeping people alive and productive within society and participating within it. And the 4 of these pillars together support the overall value-based healthcare model in Europe. In 2017, the ESR wrote our first concept paper on this topic, and this was designed to introduce our members to the idea and to start a conversation within our membership. We followed that up in 2019 by asking our patients what constituted value to them. We surveyed patients across 22 countries, got a good number of responses, and as you might imagine, the top things that mattered to patients were that they get the right diagnosis quickly, they get the right scan, that there be no errors in their diagnosis. But the 5th from the top, and 74% thought this was very important, was that the radiologist be available to explain the diagnosis to the patient. 33% of respondents were not satisfied with the availability of radiologists for direct consultation with them. Now, this has not really been a traditional part of our role or the way we've seen our jobs, but patients demand it. Patients are ultimately our customers, if you like, and we're going to have to factor this into how we design our work in the future, because that is ultimately what the people to whom we deliver services want. The next thing we did was we engaged with our sister societies across the world in a multi-society project to try and expand the whole discussion. So that involved the ESR, the ACR, RSNA, the Canadian Association, the Royal Australian and New Zealand College, and the International Society for Strategic Studies in Radiology. We produced 2 papers. One was deliberately placed in JAMA in a non-radiology journal to stop this being a process of radiologists simply talking to radiologists. And what we tried to do in that paper was begin a conversation with our referring colleagues about value and radiology and how they could work together. And then we produced a much larger, much more in-depth multi-society position paper simultaneously published in 5 journals in December of 2020. And this went through some of the key points that I've been making. Fundamentally, that radiology is a key component of healthcare, that it impacts greatly on patient outcomes and must be a vital element of any value-based healthcare model, and that equally by embracing value-based healthcare principles, radiology as a specialty can contribute hugely to moving to a value-driven system. I mentioned earlier that value is what you get as opposed to what you pay, and it depends upon who you ask. in terms of defining value. This was a University of Utah study from some years ago that asked 3 groups, employers, physicians, and patients, what constituted value for them in terms of healthcare. And the answers, as you might imagine, were a little bit different. Employers were concerned about employee productivity, employee satisfaction. Cost was a significant thing, but there was an even enough spread across these issues. Physicians were much more focused on the quality of the service they delivered. And this was really the most important thing. Cost, the amount spent on it, was relatively small. The patient experience was relatively small in terms of physicians' perception of value. Patients had different viewpoints again. Quality, of course, mattered greatly to them, but their own personal experience of healthcare was much more important than it was to physicians. And the out-of-pocket expenses, the cost to them, mattered much more than it did to physicians. So value is a movable concept depending upon who you're asking. But in general, most people who talk about value in this context will use some variation of this equation, that value equates to the quality of the service delivered plus the experience of the recipient of the service in some way divided by the cost. I don't need to tell an audience of radiologists where we deliver value, but we try to enumerate this in our multi-society statement. We prevent disease, we detect it, we stage it, we diagnose it, and this includes interventional procedures. We deliver therapy, again, interventionally or by other means, and we monitor it, and this allows us offer a prognosis for patients, and there are other areas where we deliver value, including communication of information, including multidisciplinary team engagement and teleradiological practice in underserviced areas. All of these add value. This is a model that was first published in 1991, defining the layers of efficacy of diagnostic imaging. It's known as the Freibach and Thornbury model, and we used it in our paper. And it looks at 6 different levels of ascending impact of diagnostic imaging. The problem with a lot of the research that's produced in radiology, and I know you've just had a research-orientated session here just before this one. The problem with a lot of the research that's published is that it focuses very heavily on the bottom layers of this hierarchy. So, for example, we're all used to seeing lots of papers about new MR sequences, and many of the papers we see are about the technical efficacy. Does the sequence perform in the way that technically we expect it to do? And there will be papers about its diagnostic efficacy. Does the new MR sequence diagnose disease or identify disease in the way we expect or want it to do? There are fewer papers on diagnostic impact. Does the new sequence actually make a difference in terms of our ability to diagnose patients by comparison to what was available before? And there's very little literature in the radiology journals about the higher level impacts. Does the new MR sequence actually make a difference in terms of the patient's therapy and management and ultimately their outcome and return to society and therefore societal outcomes, socioeconomic benefit? And one of the things that we've been doing in our multi-society work and through the IS3R is trying to emphasize the point that we need to focus more on high-level research in order to demonstrate the value of what we do. And there's been a bit of a dearth of this in the radiology research community until recent years. So to put this into practical terms, if you're a 42-year-old previously well patient with a 2-week history of low back pain, you may want an MRI of your spine done on the fanciest, newest, most expensive MRI scanner and reported by the best trained and most competent radiologists you can find. But the likelihood of that making a difference to your ultimate outcome and your return to normal function is pretty low. That's probably only effective at levels 1 or 2. On the other hand, if you're a painter and you fall off a ladder and you hit your head and you have a high likelihood of an intracranial vascular injury, you need a CT brain, and the CT brain done on a 10-year-old scanner in a small hospital and reported by a general radiologist is much, much more likely to have a direct impact on your outcome and on your return to participation in society. It's much more effective at the higher levels. So effectiveness has very little to do with new equipment, fancy equipment, expenditure. It's much more about focused use of the resources available. I'm glad to see that there is a trend towards that type of high-level research that I mentioned, and we heard a lot about this yesterday in the Lancet Oncology session from Dr. Scott and Professor Friedjak, and these are some of the papers that they highlighted, and those of you who were here will know what I'm talking about here. So this research focused on modelling the benefits from greater availability of imaging on outcomes from a series of cancers across a large number of countries worldwide, and showed the direct benefits to society and the direct savings that would emerge from better resourcing of imaging. The International Society for Strategic Studies in Radiology has tried to take this value-based radiology concept a little bit further. In 2021 and 2022, we engaged in a series of workshops and retreats in an effort to define practical things we could all be doing to enhance the value that we deliver in radiology. We set goals in metrics and performance enhancement, performance improvement initiatives, and in terms of influencing the motivations and behaviours of everybody involved, patients, referrers, ourselves, and industry. And we came up with a series of practical steps that we can and should take to increase the value of radiology on a worldwide basis. I don't have time to go through all of those, but I want to focus on just one of them, relating to appropriateness use criteria. And again, we heard about this yesterday in another session. We're all familiar, I think, at this stage with clinical decision support tools such as the ESRI guide that seek to influence the behavior and the requesting patterns of our referrers, and this is all extremely valuable and actually does add value. What we'd like to do is get greater buy-in to this from our referring colleagues, non-radiology specialty societies, and potentially to include don't perform imaging if imaging isn't really appropriate as an option in some of this. We know that clinical decision support does have an impact before imaging in guiding practitioners to the best choice of appropriate studies, appropriate requests. This is how the ESRI guide operates. There are other tools out there, but this is the one with which I'm most familiar. So as Professor Brklicic showed us yesterday, what happens is you have a clinical scenario, you put in the demographics, you put in the specific indication, in this instance a 61-year-old man with an acute headache and a normal neurological examination, and you'll be given a series of potential tests you could ask for. The screen you'll see will tell you the relative radiation exposure of the different investigations, the relative cost, and it will also show you the relative appropriateness with backup references as needed. So if something is scored at 1 to 3, it's probably not appropriate. If it's 4 to 6, it may be. If it's 7 to 9, it's likely to be appropriate. In this instance, at best, a CT or an MRI brain may be appropriate, but potentially doing nothing in the acute setting may be also appropriate. In a different scenario of a 20-year-old female with a head trauma and a likely intracranial vascular injury and bleed, you'll have a much higher level of appropriateness for CT and or MR, potentially with CT angiography as necessary. So this is how CDS works, and we know it makes a difference because this study from Virginia and many other studies like it have shown that. This study from 2018 looked at the proportion of studies that were of low utility or not indicated according to CDS criteria before the CDS was introduced into the chain. 11% of studies were of low utility. Only 2/3 of study requests were actually indicated. After CDS had been put into the requesting chain, the low utility studies halved. The appropriately indicated requests went up to 82%. So it does influence requesting behavior. Equally, clinical decision support can be helpful after imaging. It can be helpful to radiologists to guide us to making the right recommendations. This is a study from Boston from 2015. What they did was they looked at the recommendations made by reporting radiologists in terms of follow-up of lung nodules detected incidentally on chest CTs. Before CDS was introduced into the loop, less than half of the recommendations actually matched the guidelines for lung nodule follow-up. After CDS became available to the reporting radiologists and they could consult it to make their recommendations, the appropriate recommendations went up to 96%. So CDS helps. It's important when we talk about value to emphasize the point that under-resourced radiology is a bottleneck to healthcare and can have a disproportionate influence on the value of healthcare delivered. This study from about 15 years ago from the US showed that if someone attends an emergency department and has a cross-sectional imaging study requested, the average length of stay goes up by at least an hour. In my country, it would probably go up by substantially more than that. We know that if hospital imaging services are under-resourced and cannot cope with the demand placed upon them, that delays patient throughput, delays patient discharge, and thereby degrades the value that the service can offer to the community. Equally, if radiology resources and availability to primary care or to outpatient facilities are under-resourced, that tends to result in patients being thrown on the more expensive hospital-based services, which is again a poor use of resource and a degradation of the value being offered. Will AI fix all our problems? Will it make value inherent in what we do? I don't know. In some ways it probably will help, at least. This is a diagram many of you will have seen from Hugh Harvey that shows the various stages from requesting a study right through to the communication of results to the referrer, the various stages at which AI can influence or have a role in the imaging chain. And undoubtedly it will help with some workflow issues and possibly help with some interpretive issues for us. I'm indebted to Jim Brink in Boston for this slide. This is a typical MR lumbar spine report, the kind of report most of us generate on a regular basis. It's text heavy and it's a little bit difficult for the referrer to define exactly where the problem is from such text, yet it's all very accurate. The AI tool that Jim showed when he showed this slide takes that text and automatically translates it into a graphical description of the severity of stenosis in each exit foramen and in the central spinal canal for each level imaged. It then links that to a specific image from the data set so that the referrer can instantly see what's being spoken about and will show any change over time if previous studies are available. So this AI tool very simply translates the text into a graphical display that is much more easy to understand. And this is one of the many ways AI will help in terms of adding value. So in general, to sum up, how are we going to enhance value in radiology? As radiologists, we need to engage with our referrers. We need to understand their needs and meet them as best we can. We need to assist them in their decision making, and this involves clinical decision support and many other ways of assisting them. We need to ensure we have protected time to engage in Did the power just go off? Oh, okay. We need to ensure that we have protected time to engage in multidisciplinary team activity, because that's where we really add clinical value. We need to ensure that our radiology departments work as coherent wholes rather than allowing silos develop where the imaging is reserved for one group of patient. We need to use whatever tools we've got to optimize waiting times, optimize information flow. We need to engage patients directly, answer their questions, offer explanations. We need to do the right research that I spoke about, and we need to be involved in constant quality improvement. Who gets the value? Well, the patients do. They're the recipients of our care. Equally, patients need to understand that what they need may not be the fanciest, newest, most expensive scan, but what they need is what is appropriate for their particular presentation at that point in time. Our intermediate customers, referrers, need to know that they're asking for something doesn't necessarily mean it's the best use of resources for their patients, and we need to work with them to ensure that every use of those resources is justified and optimized. And everybody needs to understand what's going on in these calculations and to know that the actions they take at any one point in time may have an influence in terms of services being available or not being available down the road for larger numbers of patients. So radiology has to be part of any calculation of value. Any resourcing decisions based on those calculations have to resource radiology adequately to maintain our value contribution. We've all got a responsibility to define and create value wherever possible and optimize the yield from what we do. We've come a long way from radiologists being in the dark room in the basement in red goggles to being central to clinical care. We have to work hard to make sure we stay there. If you work in a fee per item system, this may be about ensuring that insurers reimburse radiology activity. If you work in a state-controlled salaried system, as I do, it may be about persuading those who control the resources that radiology should be resourced. But the fundamental need is the same. We have to prove that what we do is worthy of support and investment. As we move from a volume-based system to a value-based system, we're looking for the biggest bang for our buck or the biggest bang for our becquerel. And thank you very much.